Hello, good afternoon, everyone, and welcome to our webinar today, whose focus is looking at the linkages that we can make between lessons learned from a vaccine study that was done a couple of years ago by Dr. Tapati. Several lessons that she learned from there concerning community engagement. And we want to see if there are lessons that can be drawn from that study into the COVID-19 response in the different places where we are. Dr. Tapati, if I can just give a brief introduction of her. She's assistant professor in public health at Fort Lewis College in Colorado in the USA. Hi, Dr. Tapati, and welcome. She has a prolific practice in teaching, scholarship, and service roles that include a TEDx talk, which I would encourage you all to view, please, on YouTube. We will share the link shortly after the presentation. Her profile, she works to advance public health policy and systems to address global health disparities with focus on sexual and reproductive health, chronic diseases, and biomedical prevention tools. This particular research was oriented towards translational to program and policy advocacy through the application of ecological frameworks and community-based participatory research, which aims to reiterate community engagement to realize social, relational, and ethical determinants of health policies and programs. So that means she looked quite a bit at policy makers as well to the level of community engagement. She has a PhD in public health from Indiana University in the US, and she has 3 masters in social work, population studies, and human resource management from India, certifications in participatory research, participatory program management from Wageningen University in the Netherlands, and health education from National Commission for Health Education Credentials in the USA. So Dr. Tapati, you're welcome. And to all our participants, you're most welcome. We will have a presentation which is going to last about 40 or so minutes. And then we'll have a couple of remarks and we'll open the discussion for questions and comments and any other inputs that add to the conversation. Thanks, Dr. Tapati.
Thank you, Edzarai. That was such a wonderful and a comprehensive introduction. And so let's go directly to the presentation. I think you need to enable me to share the screen.
Okay, you should be able to share the screen. You are one of the panelists, yes.
Yeah. Learning.
Okay, great.
Tactics. Yeah. So let me just. So thank you to even all of you from whichever part of the world you are participating. Hello, good morning, good afternoon, whatever time it means. It is 6 a.m. here, and we begin with something which is very close to my heart, community engagement as an effective strategy for health communication and even in building evidence towards policy making. As Edzarai has already laid it out, I would briefly go through my own PhD research, which is on community engagement as a strategy for vaccination in India. And thereafter, we would discuss on how it can be or how it should be framed in the COVID-19 times. There are some ideas as we are all going through various webinars, looking into news, all the updates of COVID which we are happening, and as we are seeing science and policy unfurling in real times, we would like to see how community engagement, what is the framing which is happening, and are there ways to operationalize it across various subpopulations. And thereafter, there would be questions and comments from the audience. That said, I would say that I'm no way an expert. I am a doer. I am a translational researcher, mostly focusing around issues of sexual and reproductive health and biomedical tools for disease prevention, and try to look at things from an ecological perspective, specifically in the field of community engagement, or in the domain area of community engagement. My particular understanding is there are social, relational, and ethical gains of community engagement, which needs to be looked into more deeply, or discussed more deeply and advocated for more deeply, rather than just looking at the outcome indicator or the health outcome indicator, which mostly research, implementation, and intervention has focused on. And again, that said, as we lay out, or as we discuss on the framing components of community engagement in the COVID-19 scenario, I would say that it has much to do with not to give an array of recommendations, but just to share, as I have been learning through various webinars or readings and media briefings which are happening, as I have been learning through it and trying to do a meaning making within myself of community engagement in this whole scenario. So coming to my PhD thesis, it had two particular aims. One was how policymakers, or rather I would say vaccine decision makers in India, conceptualize community engagement and how they have fostered it, and thereafter identify barriers and enablers of doing community engagement. Now, as many of you would know, India is one of the most densely populated countries in the world, having one of the biggest vaccine cohorts in the world. And that's how I thought that how people are reached out to, how vaccination is made possible out there would be something very interesting to know. What happens, what does not happen, how some people get vaccinated, or how some people take positive vaccination decisions vis-a-vis some populations who might be vaccine hesitant. How do decision makers really handle all these different nuances of scenarios? It is not just an efficacious vaccine to an effective vaccination. There's a huge and a complex journey, and no country could have been more complex and more interesting than India. Of course, India is my motherland. India is the country where I lived and worked for many years, so that comfort zone was also there. So that was the reason of doing this PhD, very close to my heart. And also, why did I choose decision makers? Because for some reasons I thought, or my intervention, I thought that it must be interesting to understand that how does the supply side, as we define in many vaccine literature, how does the supply side look into vaccines, look into communities, or how do they conceptualize, how do they visualize, how do they plan? So very briefly, and kind of just some snippets of some vaccines and some incidents in India, there has been a very mixed history of community engagement across different vaccines. As much as we see that polio has been eradicated in the country, polio vaccination has been one of the biggest decentralized program the country has had, and it has been an example for the whole world. One would see that there, as much as doubts, myths, misinformation of communities have been addressed through the vaccination programs, there has been a whole lot of frontline healthcare workers who have been providing counseling to parents, who have been providing the vaccines. As much, we have also seen that communities are becoming suspicious about vaccines, or the lessons learned has not been documented properly. And I'm sure that, and this has been for introduction and uptake of many vaccines. Later, we saw in the case of HPV vaccine, the demonstration project was stalled because maybe community engagement was not done in an appropriate way. And since then, in 2010, when the vaccine was stalled, until now in 2020, there has been only 3 states in the country where the vaccine has been introduced. Similarly, we saw in the recent measles rubella vaccine that there were WhatsApp messaging and people got confused, or there were social media outrages concerning the measles rubella vaccine, something which we have seen in the US also. So kind of there has been various flavors of community level backlashes. Despite the whole effort of decentralized mechanism of delivering vaccines, counseling people, working through vaccine hesitancies, various vaccines, various introduction processes, but you see that at various times, community backlashes, vaccine hesitancies have been huge, or has delayed vaccine introductions in different countries, including India. So what I actually did was, I did interviews, key informant interviews of, I'll later describe the population whom I had interviewed, followed by preparing field notes of those interviews, reviewed policy documents, and then had a member check-in meeting to validate those findings, and which I triangulated. And that is my PhD research actually. So it has been a sequential qualitative process, initially identifying around 30 key decision makers in the vaccine arena in India. Out of those 30, 25, this gives you a timeline. And it has been a snowballing process, one person introducing me to the other, and that's how I could reach to everybody. Vaccine decision makers, by vaccine decision makers, I mostly mean people in the ministry, in the National Health Mission, in technical bodies, in UN bodies, some representing donors and international NGOs, leadership in the donor organization and international NGOs who have been playing very key role in vaccine policy making, vaccine dissemination, and technical inputs to vaccine policies and guidelines. So 25 such decision makers finally participated in the study. Similarly, 24 vaccine documents, which includes FAQs, which is frequently asked questions about different vaccines, vaccine policy of the country, different guidelines of how to reach out to different populations, which were published between 2010 and 2020, and mostly jointly by the Ministry of Health and Family Welfare in the country, National Health Mission, UNICEF, and similar organizations. And I would like to also mention that 2010 and 2020, this time is important because this was declared as the decade of vaccines in the country. One day member check-in meeting was held with all the participants and their teams, and the preliminary findings were shared and validated by them. What we majorly discussed, or how we majorly, my PhD, my thesis looked like, or the research looked like, was first was perception or conceptualization of community and community engagement. How did the process of community engagement evolve in the vaccination or vaccine domain in the country? What are the partnerships, capacity building exercises to advance community engagement? What are the resources, which was included, financial resources and human resources? What has been the examples of leadership fostering community engagement to promote vaccination? And what has, and examples of key barriers and key facilitators which promote community engagement? And especially the last two points, the examples of fostering community engagement, barriers and facilitators of community engagement, are things which I feel would be most pertinent and most relevant in today's discussion when we think in the context of COVID-19, because the communities are, of course, involved here. All of us have been affected as far as all of us are susceptible. Transmission-wise, also all of us are equally responsible and equally can be safe. So I think those 2 points could be very important in the context of COVID-19. This is just for the researchers who might be here. In terms of conceptualization of community engagement, mostly we had 3 or 4 kind of responses. It could be egalitarian, it was evolutionary, it was mostly from an ideal perspective how leadership saw it, and it was more to do with organizational interventions which the leadership was doing for the uptake of vaccines in the country. Evolution, most of them compared it since the polio times and how it has evolved and become a more of an evidence-based approach, strategic. Many of them being in the field for more than 7 to 10 years or even more than that, had very strong personal narratives to share and could even share how the country and the field and the whole lenses of how we look at community engagement has transformed over the time from being very utilitarian to trying to get more egalitarian or even more with a flavor of empowerment in it. Resources, we did discuss elements of finances and human resources, which is there or not there rather, in terms of specifically for community engagement. Partnerships were mostly with global organizations, local organizations, and with local NGOs and other informal civil society or community-based organizations. Enablers, as we go through the findings in details, you would see that how local level, again, community-based organizations or the frontline healthcare providers did play a huge role in making the entry or strengthening community engagement vis-a-vis community level barriers were mostly at an individual level, community level intersectionalities, higher class, caste, gender issues, which played a role, fear and misinformation, disinformation, lack of trust on the authorities, and communities feeling, or rather decision makers making the comment that of lack of direct engagement or lack of an egalitarian engagement with the communities. So we just go into the details. First, we discussed on how do decision makers conceptualize communities, and as you see in this table, it was more to do with the key or the priority populations, the vaccine eligible children and their parents, and local stakeholders like frontline healthcare workers, members from the CBOs, club, self-help groups, NGOs, members of local technical bodies. All these were defined as key populations and communities. With gatekeepers, people who were vaccine-resistant populations, anti-vaccine lobbyists, there were a kind of a mixed feeling. Some considered them as communities, some considered them as their mind frame needs to be changed, but did not consider them as part of the community. There was very kind of ambiguous or kind of, again, mixed conceptualization if NGOs were, local NGOs were communities or not. Some of them felt that because they made the way of the leadership to the villages, to the remote communities, they felt that they were parts of communities, whereas some felt that they were not communities, but they were mediators, or they were facilitating the process. Activists, some of them felt that activists, and again, anti-vaccine lobbyists or people having some anti-vaccine sentiments would not be communities. And again, with media was the same flavor. Some thought that they were part of the community, some thought that they were different. They were not part of the community. In terms of fostering community engagement, here I would say that all the decision makers I had interviewed, it came across very strongly that fostering came initially was initiated by an individual, then owned by then you get gathered, the political will was gathered and it was institutionalized. There was a whole range of fostering of community engagement. And as you would see from this whole spectrum, there were examples of imposition of vaccination, where somebody said that we had to hire a muscle man to convince resistant communities during a vaccine introduction. Vis-a-vis, there was, and it ends by saying the end of the positive community engagement, where the communities are empowered and where a respondent says that some journalists had adverse reports, but my community advisory board met the journalist and said that we would speak for you and we would say that you have done everything very ethically. So kind of you see how not just the flavor of community engagement has a whole range, but also how communities' responses have also changed between where vaccine has been made very compulsive on them, vis-a-vis where it is more consultative and more empowered. This is just a very short overview of how the evolution has happened. But overall, the essence which I got was, initially it began as a donor mandate fulfilling criteria. Thereafter, the understanding that communities need tailored responses or communities need tailored engagement methodologies, to now more often more of moving into a more egalitarian understanding of having community members also in advisory committees, in technical bodies, and where they are having a say on what on the community scenarios and what they would want or what they would not want. This is basically, again, a snapshot of community level facilitators or community engagement facilitators and barriers. At the policy level, some key things which I would mention is there has been a political will for community engagement and resources for community engagement. There were examples of direct emails from the ministry to the communities where communities have demanded for vaccines. Vis-a-vis, the barriers have been mostly a utilitarian or a paternalistic approach for vaccination rather than community engagement. Even when the interviews were going on, it was at times, it was more of the vaccination outcome which the respondent was focusing on rather than how much of community engagement has happened. And that had more to do with that community engagement did not have any specific indicator to itself, neither process or outcome indicators of community engagement. Rather, they were all embedded with the vaccine outcome or the health outcome which we are looking at. And that has been one of the limitations of community engagement strategies, because in that ways, when you do not have a process and an outcome indicator, it is nice to say that community engagement is important, but how effective it has been, it is very difficult to measure without an indicator. At the communication level, as in many countries or many locations, the behavior change communication materials, publication and dissemination to them into the most remotest of the communities made a difference. But then most of the behavior change communication materials were very, I would say, more concerned about, again, vaccination outcomes and were more similar. They did not mention about the community level power equations which existed. Like in India, you have caste, class, and gender-based hierarchies, which to a huge extent determines who is coming to your camp and who is not coming, how things are different in a gendered way. And those elements are somehow, so it was more clinical than maybe socio-behavioral, if I might say that. At an organizational level, formal partnerships between national and local stakeholders was the key facilitator of how decision makers or how community engagement was actually done. But then in many places, lack of any monetary incentives to communities. And if the community feedback was used, how it was used and how much of it was used was not very clear. At an interpersonal level, again, tailored behavior change communication material and in print, electronic, and social media, more and more the Indian government is taking up onto social media with communities, which has been very important. Even in the mission Indradhanush, which is the key vaccination program of the government, the logo has changed over a period of time. The language has changed. So something which used to say that be wise and vaccinate your child now really talks about that it's available for 7 days. It shows a rainbow of 7 colors and says that it's available 7 days, and you can and give these many vaccines to your child to make the child to immunize the child. So it is no more a blaming or no more a demand side lacune which it showcases, but rather showcases the importance of vaccinating or immunizing a child. In terms of barriers, some of the language in the adverse event following immunization were very complex, and there was no tracking mechanism of how knowledge, attitude, behavior, and practice actually changed over a period in time, especially among vaccine gatekeepers, which is very important because that actually measures that how effective community engagement has been with different populations and how vaccine hesitant populations or vaccine gatekeepers have really become or not become vaccine confident populations. So tracking of that wasn't there. At an individual level, because I was interviewing national level decision makers, there were not many examples of individual level any kind of factors which were found. Howsoever, there were various examples of individuals taking a stance, making things possible, making vaccines reachable to a very remote area or underserved population, just with their with their individual enthusiasm, including, like at one point, a respondent mentioned that he had to really negotiated with the government of India to have a helicopter to deliver vaccines to a particular population where no mode of transportation would reach. So there was some such exemplary individual examples, but it was again not really institutionalized. That said, I would say that here it's a time to pause and think how community engagement looked like, or to me, as I did my own reflections or internalizations, I would say a couple of things which I pondered on, that communities had, decision makers saw communities in very specific 2 buckets of positive communities who were vaccine supporting communities and negative communities who were vaccine resistant or gatekeepers of vaccinations. The second point, which I mentioned a couple of times earlier, community engagement was fostered more by individuals than owned as an institutional process. Decision makers themselves did not perceive themselves as communities, which was very surprising. Lack of community engagement metrics makes it measurement much more tougher. And interventions and communications for vaccinations in most cases were thought as community engagement, but again, there was a parallel acknowledgement that this is not actually engaging with the communities. In this process, you are just supplying vaccines or giving vaccines to active participants, but not engaging really with them. In terms of media, it was more of handling the media or stopping negative media. Howsoever, there was no plan or no strategies to handle rumor management, especially when it happened in the fora of social media, again becomes very important in the context of COVID-19. There was a mixed opinion between engaging celebrities and local champions, that who would actually play a major role in making communities more enthusiastic, or where would communities really identify themselves with celebrities or with local champions who were vaccine ambassadors. One thing which came out very strongly was the relational gain of community engagement, which is trust building. And trust building decision makers came out as it needs dedicated resources, it needs specialized personnel, it needs compassionate conversation, and it also needs talking about various memories of coercion which communities already have. And they, in many different communities, we have seen this, that anything coming from the government or anything coming from the West or the science fraternity is generally doubted. And those memories of coercion needs to be erased, needs to be dialogued with communities in a very deep and in a very personal way. Now, coming to the COVID-19 scenario, all of us are pretty much aware of what is happening, how things are unfurling, so not getting into those details. In terms of community engagement, I strongly feel that institutionalized community engagement is required rather than very sporadic activities. So that solidarity among the high-level decision makers, policy players is required. Deep, meaningful, and empathetic engagement is required. Here, I would specifically mention about the SALT and the LIVES. SALT is by one organization working on HIV prevention, which talks more about stimulate, appreciate, listen, and transfer. LIVES is the domestic violence or the gender-based violence tool which the World Health Organization uses. It talks about listen, inquire, validate, enhance safety, and support. I thought that these were really very key towards making engagement with communities more deep, meaningful, and empathetic. It has to be robust, more robust than the minimum community engagement or the maximum community engagement and the two-dimensional information flow, which has been happening until now. It has to be more multidimensional, considering the complexities of different scenarios. And one assumption which I thought was very important not to make is that knowledge, when it comes from a global or a national level policy or decision maker or a guideline, it is thought that as if it would, in a very linear process, get diffused into the communities, and communities would accept them as a part of and make it as a part of their local belief system, which is not always the case. So we have to come out of that and look at community engagement as a more upstream strategy, more institutionalized strategy. For this, I think I have like 5 or 6 key areas which I would suggest. First is building the political will for community engagement, and where decision makers' intercultural humility, compassionate conversation is required to build the knowledge and also establish trust with the communities. There has to be strong voices from marginalized and minority communities in leadership positions. In my case, what I saw was elite interviews helped to a huge extent. Rather than across the literature review which I did, I saw that most of these studies around community engagement were done with communities or at the most frontline healthcare providers. But doing elite interviews or talking with decision makers gives a very high level perspective and gives also a real-time understanding of what they are doing or how they are wanting to shape up community engagement in the context. Also makes them accountable to a huge extent. And also understand that community engagement is not just a bunch of interventions, but it needs to begin, the thinking of it needs to begin at a high level. The metrics which I had already mentioned, you can only achieve if you measure. So devise community engagement performance and outcome indicators in the COVID-19 policies and policy and programs which we are having, and also trying to incorporate them in the surveillance instrument. Knowledge, attitude, behavior, practice studies with respect to personal protective equipments, community mitigation strategies, and vaccine communication, because these what we are seeing are highly different and differs massively across various subpopulations. Men and women, rural and urban, again considering the digital divide in place, again considering that how messaging is also different, or also changing as we are coming up with different research data. Stigma and barrier studies needs to be done. Like we are seeing that domestic violence or intimate partner violence has increased in COVID-19 times. So do stigma and various studies among intimate partners, among especially abled populations, develop practice updates. Like we know that for COVID-19, one complexity is we don't have all the answers in place. So why not develop practice updates for unique community engagement strategies during COVID-19? How you reach to maybe transgender populations, to rural populations where digital communication is very low or poor. Subpopulation-based mapping of knowledge increase, misinformation and disinformation, how are you handling them in COVID communication? So that these are studies which I would like to propose. Harness local partnerships if incentives can be provided. We are seeing it here among Native American and indigenous populations that many of the contact tracers belong to the populations themselves. Our behavior change communication materials developed in local dialects and translated in languages are contact tracer trained in local languages, because everything is so very contextual, including physical distancing and putting on face covers. Use subject matter experts to create local knowledge base, encourage local partners and community champions to talk about controversial topics and provide clear, consistent information. And here, when I say consistent, I know that things are changing, and that is where the trust building plays a huge and important role. Establish relationship with the local media such that they are also local level interventions are being reported and good practices are being reported. Look beyond demographics for the diversity of perspectives, like engaging with the most difficult to reach populations for trusted information. Allocate engagement budget for minority stakeholders and comprehensive analysis of effective legislation, underscoring inequities or underscoring elements of intersectionalities and racism which persist among vulnerable populations. This is something which, again, most of us are grappling with as we are moving into an online environment, online field engagement, online community engagement, online contact tracing. Now, a couple of years back, or as much as I have learned and read, studied social work or done field work, we didn't have the concept of virtual field work in public health. Now newer mechanisms of hybrid and telephone-based fieldwork and virtual community, understanding of the virtual community is coming up by and by. So as much as we need to be trained of how these virtual communities are or how would they function, communication, the familiarity, making the communities familiar with the digital tools and getting good data, trusted data through these digital mechanisms gets very important and very critical and crucial. So creating compelling online engagement strategy and content, developing social media plans, ensuring availability and familiarity of interactive mapping or visual tools with the communities, facilitate online discussions where they do not feel threatened, where they do not have the have any fear of digital outrage happening over social media or any such fora. Use SMS, which we have been using in the vaccine arena, in the sexual reproductive health arena, but I think more and more of interactive voice responses. Some studies in Kenya and Africa show that interactive voice responses have shown good results. Computer-assisted telephone interviewing is another mechanism which is coming up, but we are yet to test how viable it might be. And for general population service, processes like random digital dial, which might have lower rate responses, some skewedness in the data, but again, a mechanism which one can try. And of course, last and not the least, of course, the behavior change communication messaging needs to be more personalized while keeping in mind the aspect of self-altruism, that when a person is safe, when a person is using masks or practicing health hygiene, he or she is not just protecting himself or herself, but is also doing good to other community members or family members. So making messages personalized, but having the component of self-altruism is very important. Provide visual and auditory reinforcement, clear messaging in case of different timeframes, and considering reopening in different scenarios is important. So we have to be like we cannot have a set of communication material which functions throughout, but again, we might need to change it, revamp it, revisit it, and address communication gaps, which are basically hindering tracking mechanism among underreached and underserved populations. So those are some of the important things, and that is it.
Oh, thank you very much, Dr. Tapati. Thank you for that very engaging presentation. I think the question that we are asking in the topic is that how can the lessons you have brought out so clearly be adopted in the COVID-19 response? And I think there are quite a lot of parallels already. Now, we are just going to hear from some remarks from someone who's actually working on the ground. She has been working in terms of community engagement for some years. Her name is Eunice Ganganga. She's the Executive Director for the Hospice Association of Zimbabwe. Eunice has been doing community engagement in different contexts for more than 20 years, if not more than that, from the HIV response to cancer issues and so on. And just to bring a voice from the ground from her, then we'll open it to questions. We have seen the questions in the chat. So Tapati, Dr. Tapati, if you can have a look at those also in the meantime so that we can address them quickly in the time that is left. Thanks, Eunice.
Okay. Thank you so much. Hello, everyone. And thank you, Dr. Tapati, for an excellent presentation and research. Definitely, it has set some scenes for people to take lessons from your research and carry forward in community engagement. I would
Eunice,
like to say...
sorry, Eunice, did you switch off your video or did we just lose it? Okay, that's better. You're back. Okay, good. Yes, yes.
Okay, so I started by saying thank you so much, Dr. Tapati, for an
Eunice,
excellent presentation. Can you hear me?
So, yes, Eunice, we are receiving you very clearly, but I think it's a sheet of paper that's in front of the camera.
Oh, that's this.
Yes. Okay, now you're okay, good.
All right. Thank you so much, Dr. Tapati, for an excellent presentation and research. Definitely, it has set a lot of questions and a lot of energy on the people who have heard your presentation for taking forward some of the issues which you have brought forward. I would like to say that communities are the front line for any response for any pandemic. And therefore, communities are therefore very important key stakeholders. And it is communities that hold the keys for any success to happen, for us to be able to solve any issues that pertain to communities. The communities themselves hold the keys. And therefore, I would like to say during this time of COVID, I think it is very important that we engage our communities so that we move together in a collective manner. And I think I've learned also from what Dr. Tapati has said, we need the communities to be able to follow whatever we are proposing so that we move together. And for me, I think I take lessons from what has happened in Zimbabwe in terms of HIV pandemic. And I'm sure there was a time when you were hearing 300 people dying a week, and it needed us to engage our communities. And we took the principle of leaving no one behind. So we started with local leaders, traditional leaders. Here we say local chiefs, local authorities, the civil society. We engaged the churches. We engaged the private sector. So everyone was brought together so that we can manage the pandemic. And I would want to say, I think from us, it was a sort of a partnership. We brought in, when we went into our communities, we said we are partnering with you. So there was no one who was more superior, like to say the decision makers, the national leaders. No. We actually said at the community level, they are the ones to make decisions so that we can move forward. And during that time in Zimbabwe, we had to take a model, which is community empowerment model, which had to take to our communities, starting with the traditional people, starting with the gatekeepers. There are lots of gatekeepers. If you understood from Dr. Tapati's, there are others who are there just to say no, even if they don't know whether it's going to be good for them or not. So really, we took that step of this model to engage our communities. So I would want to say that when you engage communities and you say we are together, you promote trust. They need to know that you are bringing the right things. And also in terms of COVID, again, when you bring, you are saying you have a responsibility. Let's share the responsibility of any pandemic. So for us, we went to the communities and say, this is your responsibility as well. You need to solve problems that affect your communities. And people were eager to jump in and follow what was coming in. And community engagement is our opportunity as well to empower our communities, to give them the right information. If you look at COVID, there are lots of information flying all over. And some of them, if it's not the majority, are not true at all. So when we engage our communities, we give them the right information. It's our opportunity to educate. And also it's our opportunity to disseminate whatever statistics are there so that people are aware of what is happening truthfully. And it's also for us an opportunity to use our media as a tool for community engagement. And also really before you know media, the moment you say media, you think they are bringing the things that are not correct. So if you engage them and to work together, then we'll be able to work together. I would also want to say, when you engage communities, it's an opportunity for us to say communities, you need to demand the services. Now in COVID, there are lots of things, even PPE, people don't have. Even clinics, they don't have enough. I mean, we have been hearing about it. But if we engage our communities, they are able then to demand, and also as well as to be able to they are also very good, our communities, in resource mobilization. You'll be surprised how much they can do, even small as it might be, but they are willing to do also and donate as well. So even our palliative care, when you go in our communities and engage them, they'll be able to know that even with COVID, palliative care is still very relevant and they can demand that. I would also want to say our communities, if we have engaged them, this is what we have seen from our experience, they can monitor what is taking place. And also then accountability comes an issue. They can also monitor if the leaders are doing the right things, if the resources are being used correctly. So our communities can be our eyes. So we need to engage them for them to monitor also. And they can also monitor some of the services that are not taking place because of COVID. They can actually tell you that the people who are going for their usual appointments are no longer, because people are concentrating on COVID. So they can be our eyes as well if you monitor them. And I would want to say, for community engagement, it's not a once-off. You need to perpetually to continuously go back and share some information with our community. So it's not a once-off, it's continuously sharing. And then, of course, before I just end, I think we've heard a lot from Dr. Tapati. I would want to close by saying community engagement really should be at the center of COVID pandemic. And also to ensure that what is done in a collective manner. We don't want to leave anyone, especially with the information I was talking about. So effective community engagement has the power to change the course of this pandemic. So I would want to say continuously, let's continue looking at what we have gained before and what we have done and use it with what is happening now with COVID era. and we can say together, I think we can achieve. And especially tapping also from Dr. Tapati's research, I think we have learned a lot. So we can tap, use what we have already had before, our experiences with what is coming up. And I think with that, I think we can achieve. I would want to say thank you, and I can hold for any questions if you have. Thank you so much.
Thank you, Eunice.
Thank you very much, Eunice, for those remarks. If you could, if we can go back to Dr. Tapati, I'm sure you've had a moment to look at the questions in the chat. There's a couple of questions in the chat, but also a question from Sherry in the Q&A section. So if you can maybe just follow them from the top. I think the ones about the media and so on, you've already addressed in your presentation later on, but I think let me give time back to you.
I'm first, there's just one question in the Q&A, and then I'll go to the chat section. So in the Q&A, it's like an experience from International Red Cross along with the National Red Cross Societies takes community accountability and engagement in a very systematic manner. Community feedback is systematically captured and feedback provided back with revisions on behavior change communication materials, which is like wonderful. Your menu of suggestions are very helpful. What would be the 2 or 3 key takeaway messages when it comes to COVID vaccine rollout when it is available? So I think, and this is by one of my professor during my undergrad years, Sherry Joseph has asked this question from the IFRC, and I would say, of course, Sherry, I do not have any ready-made answers, but for vaccines, once they are available, I would say that vaccines are one of the public health tools which can bring in health equity. So information about the vaccine science needs to be clear. As of now, as we are going through the vaccine clinical trials, and many of the vaccines would go through their phase 3 clinical trials, many human volunteers would be required for that. So having vaccine research science communication to people in a clear and a candid way, having consistent, ensuring that you have clinical trial volunteers and you know how to retain them through the process of clinical trial is very important. Second is, given the whole history of vaccine-related dilemmas, vaccine-related hesitancies across different communities in different points in time, I think very consistent effort is required beyond the scare tactics of you will die and so you take a vaccine. The scare tactics unfortunately creates more of backlashes, if I would say, community level backlashes, I would say, rather than building a confidence on the vaccines. So looking at it from the science, communication needs to be very clear, candid, and even clarifying that why things are changing. Not giving people wrong hopes in terms of vaccines and its availability. And when it is available, I think the world and the decision makers and the policy makers need to come together beyond the politics of resources and make vaccines available to all, equitably to all. There is nobody, I know there are some framing of it where they are considering populations who are most at risk vis-a-vis lesser at risk. But I think in this context, each life is important and each life is at maybe more or less a comparable equal risk. So ideally, I would say that availability of vaccines to all. Now going to the chat section, Wedzera, would it be possible for you just to Just to
I can help here just to highlight, yes, you're going to have to keep your answers very brief now because of the time. There's quite a number of issues, but there's a question about what does intercultural humility mean in the context of community engagement? I think you might want to quickly just answer that. And also, someone is talking about the community hesitancy in terms of vaccine adoption. Was it mainly people that completely stayed off, or they were dropouts? And what insights did you get from dropouts who sort of started and stopped? Yeah.
Okay. So I would first come with intercultural humility. Many of us take a pride, especially people who have transcended from fieldwork and learned a lot from fieldwork or working with the communities. While we take the pride of working with communities, it is still a very touristy mode of being with the communities. Living with them, learning from them, that attitude, or at times even unlearning some of our technical or unlearning some of our stringencies with the knowledge which we have, and trying to understand that where traditional knowledge could actually mingle with the scientific or the new knowledge which is being generated. And I think that is where I talk about intercultural humility. Just going to a village or picking up some of the dialects and wearing the attire which they are wearing doesn't make you a part of the community, as much as we need to realize that maybe we are not part of that community, but that humility needs to remain, that where a person is coming from, why the hesitancies are there, what kind of historical feelings or sentiments are there of discrimination or subjugation has been there, which makes the person feel or the community feel as they feel today. So there has been a history to it. So we need to talk about those things, and that can only come with some bit of humility in the part of the decision maker, policy maker, and the researcher, where you unlearn some of what you know and listen to the communities, be compassionate to the communities, be empathetic to the communities, just listen their stories in their ways, and then formulate your communication materials accordingly. The second one on vaccine dropouts, what was the question, Vezerai?
I think it's just saying, are there any lessons that you can learn, that you can draw out from the reasons why somebody engages and disengages?
Yeah, I think the one big lesson I would learn is community engagement has to be a consistent process. It cannot be that you introduce a prevention technology or a tool or come up with something new and the community is all glad there to accept it. There would be people who would accept it readily. There would be people who would resist to it. There would be people who might vaccinate their first child but think differently for their second child, or think differently for a second dose. We have seen so much for HPV vaccines in Africa that the first dose is so regular and the first dose is high, and then there are huge dropouts for the second dose. Because the child, by then either the child goes to the middle school or gets married or migrates to a different location. So there could be very many other things, other structural factors which are deterministic to vaccination dropouts, rather than just vaccine sentiment being positive or negative. And we need to consider them also, because different populations face these structural barriers in different ways.
Okay, thank you very much. There is yet another question, but it's a multi-level question that unfortunately we won't be able to answer it in the time that's left. It's from Raj, and he was asking about the robustness of the evidence and so on, but it's quite leaning towards immunization. But let me take this last minute to just say thank you very much to Dr. Tapati and to Eunice. Thank you for taking the time to share with us your experiences in terms of the findings of the study, and also the experiences that you are getting, Eunice, from the ground in terms of engaging communities, putting them into the driving seat, and ensuring that they have control and accountability and monitoring powers as well. Thank you so much to everyone who has been here today. We've tried to respond to all the questions and issues raised in the chat. Thank you to those who are, many of us have enjoyed the session and have said positive comments in there. We are going to share the recording of the presentation. We will not, we will share the recording of the presentation with all those who have attended. Thank you so much for your time. Let me take this time to say goodbye. Our next webinar is on the 4th of August. We will send out again an invitation. Thank you.
Thank you, Edzerai, and the whole of